we've had 3 cases in the clinic just now. One was a atypical fibroadenoma,
Yes, sir.
and the other one was
Extension.
goiter with retrosternal extension. And third one is hereditary ovarian cancer, where she on screening has a suspicious lesion, which is a septate cyst in the breast. So we can discuss them one by one. So let's start with the first one.
So it was a 14-year-old girl with a lump in the right breast, and she first came to us in February. That time it was of a smaller size. It was 1 to 2 centimeter, which has now progressed in size, and it was Byrad's 4A on ultrasound, right breast lesion, and size of approx 5 into 3 centimeter.
So the patient has been under observation. In fact, the patient had presented earlier, 6 months. February would be 5 months. So 5 months back, and we had counseled her. We should not operate on fibroadenomas just like that. Otherwise, you will often see young girls coming with a battle scarred breast, multiple incisions, given lumps excised, because this is more of an ANDI, and ANDI stands for aberrations of normal development and involution. So you won't be able to, you should not be operating on all of them. Otherwise, you end up having lots and lots of scars on the breast. Now coming to this lady, this girl. Now the problem is, she's conscious of it. This time, an FNAC was also done under ultrasound control. Now that FNAC made it
Atypical
fibroadenoma. So what should that be? Now how should we approach it? What should we tell her? How frequently do an FNAC? You don't necessarily need a FNAC for a fibroadenoma.
Sir, FNAC has already showed that the report of atypical fibroadenoma, and the size is also large. So we'll go with the diagnosis of query giant fibroadenoma, query phyllodes tumor. So we'll offer the patient the surgical plan, which will be excision of the tumor and sending the lesion for frozen intraoperatively, and to find out what is the histology.
Anything different or same?
Same, sir.
Actually, see, the indications for surgery in fibroadenoma are giant fibroadenoma, which is fibroadenoma that is larger than 5 centimeters.
Painful fibroadenoma.
Symptomatic patient.
Symptomatic.
So if she wants it, then we can do it.
Yes.
Also, some people feel if there is a cosmetic concern that it is patient wants it for some reason. Although I don't think that should be an indication. You should counsel your patient accordingly. But more importantly, when you see a change in the size, the rapidly growing
Yes,
one. Ishita, in this patient, 5 months it has grown to almost twice the size.
Yes.
And the other thing is on palpation, it's a lobulated appearance. So to my mind, phyllodes also comes. And a giant fibroadenoma, phyllodes, patient being anxious, and then FNAC shows atypical fibroadenoma. What exactly do you mean by atypical fibroadenoma?
So fibroadenoma would be it would not contain the cells of the it would not contain the breast tissue. It will contain the fibrous tissue, a periductal or paraductal in between the ducts. If it is the tissue shows cells or the nuclear atypia, or there is enlargement of the cells, that could cover.
That's a good answer. Actually, fibroadenoma has nothing to do with breast per se. So if you have atypia or any doubt, the patient should go for surgery. It's always better. And would frozen be of any help?
Yes, to detect if it is carcinoma.
Can you speak louder?
To detect if it has any.
So, but actually they are not able to detect so accurately, and they won't be able to say it's phyllodes or not. We should go by wide local excision and wait for the final histopathology, because otherwise frozen puts you in that confusion always. So it's not mandatory to have a frozen. We should excise into the clear margin. And I'm not suspecting that it is cancer already. If at all, when it changes into a benign phyllodes, and we can always go for a second time intervention into this. So in all probability, patient can be managed by, now the patient is keen and we are going by the recent mastopexy approach, or we are going to go through a hidden scar. We are also thinking of attempting an endoscopic excision
As comfort is.
that we are looking at. Whether there is a change in the behavior, in the histology, in the appearance, and in the nature. And all these things indicate intervention. So we'll take up the first case more.
If also family history would be present, then also we can.
If there is strong family history present, then also some people feel that it's safer to err on the side of excising it, although that's not a copybook indication for doing it. Right, Ishita?
Yes, sir.
Your point is taken, but we cannot be citing that as one reason. Otherwise, they'll keep coming for every lump and you'll keep excising. We have that case also. We've just
Yes,
discussed
sir.
it. So
Yes, sir.
you can rest assured that it's always a balanced approach which we need to
Yes,
take.
sir.
So that case is closed. Let's take the second.
5-year-old lady with no known comorbidities came to us in the OPD. She was complaining of swelling in the front of her neck. She also mentioned that she has noticed the changes in her voice. She was also complaining of a feeling of a pressure in her neck, with difficulty in breathing at night and difficulty in swallowing also. On inspection, we found out when the patient was swallowing, there was the right lobe of the thyroid was moving with the deglutition, and her neck was also short. So after on examination, we found out that the lower pole of the thyroid lobe on the right side was going to the manubrium of the sternum, and the trachea was also deviated slightly to the left side, to the opposite side. She had come with her ultrasound reports, which showed as thyroids 4, and we have on examination also we did not find any lymph nodes. So we planned her for imaging as well as indirect laryngoscopy and thyroid function tests to see the status of whether the goiter is whether she has hyperthyroidism or hypothyroidism. And
Thyroid function tests are normal, and she is clinically not hyperthyroid. So are thyroid malignancies commonly hyperthyroid or euthyroid or hypothyroid?
euthyroid.
Mostly the cancer does not secrete, so it is rare to get malignancy in a hyperthyroid patient. We often get it in a euthyroid patient, but in about 5 to 7% individuals, you can have malignancy and also secreting malignancies. So don't think that this is the end of it. We have one more case that is going to come anytime this week. She's Graves' disease, and FNA is revealing papillary carcinoma of thyroid. This patient has retrosternal extension of goiter, and this is one indication for doing a CT head and neck. Some people
Yes.
say MRI, but for thyroid, the only problem with CCT for thyroid is the iodine that they talk about, and you can get jode-based or the other problems when you are giving iodine, but that I don't think is a very important part of it. We need to see the vessels, nerves, the extension properly, the bone properly, and to grade a retrosternal goiter, we need to see the aortic arch or innominate vein, because if it ends above, superior to it, it's grade 1. If it acts at the level, it's grade 2. If it goes below that, it's grade 3. In all patients with retrosternal extension of goiters that are grade 2 and grade 3, we keep the sternotomy set as a standby, so that we are able to. There's no point in fishing it out. But most retrosternal goiters can be taken out through the cervical route. Why? Because their blood supply is from the neck. But if there is a direct vessel from thyroid to innominate or to aortic arch, you can't be fishing it out. That's why you need to do a contrast enhanced CT scan, which is a good investigation to do. And there is usually a lot of fuss about this contrast being iodine contrast, etc. And of course, you already mentioned about IDL, which is to see the present status of vocal cord. The CT will also show you about the trachea. it'll show you about thorax. So you don't need an X-ray neck or X-ray chest for that case. CT will show you whether trachea is deviated and how far it is deviated. She has slight hoarseness of voice which has appeared, and that is what is making us suspect it. Even if the other side doesn't have a diseased gland, we will explore and we'll try to remove it. Ultrasound shows it to be mildly large on the left side as well. So plan is total thyroidectomy, and prophylactic satellite dissection is not something which is done as a routine, but in this case maybe we'll do it because we do it all the time. I don't like to go there second time, so it is better that I do it in the first go. So we'll try and do that, and that's the second case, and we are planning that surgery with the entire thing in the fitness.
Sir, USG shows that the right lobe is thyroids 3 and left lobe is thyroids 4A. But on clinical examination, there is no left lobe palpable or.
You're right, actually, clinically, that's what I was saying. Trachea is pushed so far away that they are taking a reference point as trachea and it's all getting mugged up. But if you take that as a reference point, it should be all right. Everything should be right, clinically as it appears. But you never know, there is a gland deeper, and ultrasound is more reliable than my clinical examination. Subjectively, yes, only the right lobe predominantly is involved. Now, when it comes to thyroid scoring, that has nothing to do with the size that you got, no? It's got to do with the other factors. So, it is possible that it's thyroids 4 on left side and 3 on the right. Both on, we have done the triple assessment, which is history and clinical examination, followed by high resolution ultrasound, followed by thyroid function tests to rule out thyrotoxicosis, which can lead to false positives and thyroid storm. I have discussed it
Yes,
before,
sir.
so I won't repeat it. Followed by FNAC. So how do you get false positive? The same atypia, like we were talking about atypical papillomavirus. So there can be atypia in FNAC, and that can give a false positive for malignancy. And the other thing is so some people there is a test called quadruple test. People confuse it in many ways. Some people say, your books also say, quadruple test means the triple test, which we have talked,
Yes.
and they also include the thyroid function test, which we have added. So they make it into 4. But actually, a lot of literature says it is not the same. Quadruple test is the same triple test: history, clinical examination, followed by imaging, which is a high resolution ultrasound, followed by thyroid function tests to rule out thyrotoxicosis, followed by FNAC, not histology, cytology, followed by the gene profile, the gene paneling, gene sequencing. That is quadruple according to the literature. So there is a controversy about it. It doesn't matter as long as you can test it. So you don't do it in all the cases. Which particular gene you are looking for and why in thyroid cancers? Which mutation is of importance in planning therapy? It's a BRAF mutation. BRAF mutation. BRAF mutation is usually suggestive, indicative of a radioactive iodine resistant cancer, which means worse outcome. Radioactive iodine resistance means you won't be able to get a backup of radioactive iodine if you don't remove the entire gland. So you need to be very aggressive with your surgery. That is BRAF mutation group. So they are counted as a high risk group. If you can't do radioactive iodine for testing or for therapy, then naturally you need to do surgery more aggressively. And the other one, which is done for medullary carcinoma of thyroid, which is not thyroid cancer per se, is red proto-oncogene, but that's not the gene panel we are referring to. Here the gene panel is BRAF mutation. They also have found P53 and other genes in thyroid cancers. So that included, it becomes a quadruple test. Otherwise, it's a triple test.
Yes.
Is that okay? And so much of work is required before you plan. And the risk assessment is, in women the cancer does better. The cutoff has become 50 rather than It used to be
40.
55, that it used to be 45. HSCC 8th edition has changed it. And we will plan total thyroidectomy with central leg dissection on Monday. And I don't trust frozen for thyroid. It's not useful. Frozen doesn't really help. And we don't trust frozen in most cases. It's just the central biopsy and margin assessment in some situations. Otherwise, it's very, very dicey. In thyroid, it doesn't work. It doesn't help. Is that okay?
Yes.
I was talking to you about the non-patavid tumors the other day. Did you go back and read? What are those?
So thyroid cancer, there is
And?
soft tissue tumors, some low-grade sarcomas, soft tissue
Low-grade sarcomas. And how about the RCC? So I give you the advantage of even checking on your chat GPT. Check it. Is RCC, this is just to let you know where you can go wrong. I know it by my practice. You will check it by your chat GPT. And chat GPT learning or AI learning can cause you so much of damage. You will just see. Chat GPT we found it is not one of the investigations for staging in RCC. It's not a very useful investigation. Even for pancreas, a lot of people don't like it in pancreas, very inflammatory. It has got to do with the activity and the nature of the cancers, okay? So, every information should be understood. And remember, it is not mostly understood. You have an information, but you don't know where to use it. You will lose it. Use it or lose it. That they say about the bowel also. That's why we encourage enteral nutrition rather than parenteral for a long time. Because if you don't use the small bowel, there will be villus atrophy, transgut migration of bacteria, which leads to sepsis, lack of absorption of IgA, etc., loss of enterohepatic circulation. Eventually, you're losing it, and the gut becomes a transparent tube. And what is inside is muck, so it will circulate all over. That's why guts, have them, use them. Use them or lose them. It applies to guts too, in the real sense, in the sense that you are understanding. Yes, so cases in the clinic, so they will go down in surgical clinics. People can ask questions, you can ask questions. Any questions from anyone?